Hi, and welcome to another edition of MD Insights. I'm delighted to be here today with Dr. Cathleen Khandelwal, who is the Trauma Medical Director at Fairview Hospital, which is one of our Cleveland Clinic hospitals in northeastern Ohio, which is also a Level 2 trauma centre. Kathy, welcome. Thank you for being with me today.
Thank you for having me.
So just to kick off, so what led you to trauma? A lot of different surgical specialties out there. You picked trauma and acute care. What was interesting to you and what drew you to it?
I was a medical student at the University of Maryland, and my first rotation as a third-year medical student was at shock trauma, and it was amazing. I loved everything about it, how fast it was, how quickly they were able to take care of people, how people were so sick, but often we were able to make them better. I liked the adrenaline rush, no question. But that was my first experience to inpatient critical care was in the trauma center, and I really never found anything else that I liked better. And then when I was a resident, my favorite rotations were the trauma and acute care rotations. I sort of liked being involved in people's lives when they were facing unexpected health consequences in an acute fashion and being able to help.
Yeah, well, certainly it's a fairly unique specialty for being able to help people immediately, that's for sure.
Yeah.
So the profile of cases at trauma centres can be different. So maybe you'd talk a little bit about the profile of cases that you see at Fairview and what you have to be prepared to. And maybe also thinking a little bit about the pandemic and COVID and how it's changed things, because people have been at home so much that, you know, the changes in injury profile.
Absolutely. So at Fairview Hospital, we're a hospital on Cleveland's west side. We're not in the downtown part of Cleveland, and so we do not have a very high penetrating volume. Only about 2% of our patients have either suffered a gunshot wound or a stab. Most of our patients overwhelmingly are either motor vehicle crashes or more commonly elderly patients who have unfortunately fallen. And I think the elderly patients really present a very unique challenge because often they have sustained significant injuries from even very small mechanisms, you know, falling from standing or falling out of bed or falling off the toilet or tripping over something, but end up with significant injuries, you know, rib fractures, splenic injuries, broken pelvises that can really be a significant threat to their life despite a very minor mechanism. The other thing that occurs with many of them is they often fall for a reason, and that reason is usually not surgical, it's usually medical. And so it requires significant collaboration between us and the medical services here to really try to get them back to their new normal by fixing whatever caused them to fall in the first place, whether it's a blood pressure medication change or they had a stroke or some significant medical issue that caused them to fall, while at the same time we're fixing whatever got broken when they fell. And so that's what we focus on a lot at our institution, is helping this proportion. It's about 50 to 60% of our trauma patients are actually folks over the age of 80 that have fallen. And so it's a significant amount of our volume, and we focus on that quite a bit. Now, that number didn't really change for us during COVID. They continued to fall even during the quarantine, but overall our numbers dropped almost in half during the month of April. And that's because we didn't have almost any motor vehicle crashes. As you can imagine, people weren't driving very much. And we didn't see as much penetrating trauma initially. Now that things have opened up and people are starting to deal with the consequences of not having a job or not having insurance or what have you, we have seen an increase in penetrating trauma, almost 180% from our normal numbers. It's still a small number for us, but it is significantly higher than we've previously seen. And I think that's due quite a bit to the stress of things being so different with the pandemic.
Yeah, absolutely. I've no doubt that's true. What about home violence? There was a lot of discussion in media and a little bit in literature about violence at home changing the profile of injury. Was that something you noticed at Fairview?
So in the month of April, we did not. During the biggest quarantine month, we did not see an increase in home violence. But since April, we have seen an increase in assaults and home violence. We've also seen an increase in people coming into the emergency room intoxicated at the time of their trauma. So I believe that they're probably drinking at home, and then interpersonal violence is happening after that.
Yeah, and I guess probably time as well, right? You survive the first few weeks, and then if it's an unstable relationship, yeah, exactly. Yeah, it's incredibly tough. I think the social challenges caused by the pandemic, in a way, are certainly very different and very real as part of the medical challenges. But that's also changed the way we end up having to manage the patients too. So, you guys have to see somebody, you rush to the ER, it has to be something immediate. So what are the preparations you're taking in managing trauma patients as they come in?
That's right. We did have to make some changes because we have no idea if somebody is COVID positive or not when they arrive. And that's particularly true because of the elderly population that we see. A lot of them are coming from nursing facilities, which, as we know, is a high-risk population. And a lot of them are elderly, which is also a high-risk population. So we don't know when they come in. And we've certainly had challenges of finding out people were positive after we had already finished their trauma evaluation. So in terms of taking precaution, what we've done is tried to limit the number of people that respond to a trauma. Previously, we had a lot of students and interested parties, new nurses that were learning, things like that would be present to watch how things went through. And at this point, we've really limited it to necessary personnel only. We also make sure that we all gown up and glove appropriately like we always did. But I think the eye protection and the masks have been way more important, and something that we've all focused on a lot more since the pandemic than previously. Universal precautions for us normally had to do with not getting a blood exposure. So we were more interested in making sure everybody was gowned and gloved. But now that we have to worry about COVID as well, certainly having eye shields and facial protection is way more important than it used to be.
Yeah, I think it's changed everything and will for the very, very long term, I suspect. Vaccines or not, I don't think face shields and eyewear and masks are going to go away. And so have you noticed, have you had any patients then who've turned positive afterwards who say the COVID pneumonia has complicated a chest injury with rib fractures? Because that's always one of the concerns surgically, is that somebody turns positive after surgery and they'll have a respiratory complication. And that will make them more difficult to manage from that perspective.
Yeah, absolutely. We haven't had many, fortunately, but we did have one or two patients that had rib fractures from a fall, and turns out they were COVID positive as well. Luckily, in those cases, none of them ended up trach dependent or long-term ventilated. We're very aggressive with our rib fracture management here, aside from COVID. We have a very strong pain management program that blocks these patients extremely early. And so they're less likely to have the pneumonia complications because they don't have the pain. And so that has helped us quite a bit, even with COVID, has made a big difference to be able to have the pain management side of it that we have.
Yeah, I think it's another critical part of multidisciplinary care,
Absolutely.
Without doubt. So one of the other big parts of a trauma practice is the acute care side of it. I know you've got a couple of cases later on today, and thank you for making time to chat with me. But that's certainly here at our campus has changed a little bit the profile of patients that we see acutely. We've seen some patients who are having delayed presentations. Obviously, it's become very highly discussed with cancers, that we're seeing 30 or 40% fewer cancers, or at least were for a couple of months. And we know that was just because patients were scared to come in. But it's also changed their acute presentation, that they're nervous to come in and they come in a bit later. Is that something you've noticed?
Yeah, absolutely, 100%. I think the gallbladders that we've done over the last several months have been much worse than what we would typically see. We're pretty aggressive here about taking care of gallbladders quickly. And so often we would do them before they were really bad, but patients now are waiting. They're putting up with their pain. They're trying to change their diets as best they can, so that by the time they come in, it's really quite a difficult gallbladder often. And I think all of us have seen a lot more patients that have come in with worse presentations of their gallbladder disease, more perforated appendicitis than we would normally see. And when people come in with their small bowel obstructions now, they're often profoundly dehydrated because they waited so long to come in before they decided that they needed to come.
Yeah, I think so. You bring up something else that's very important, that a lot of the COVID-related morbidity isn't directly COVID, it's all these secondary consequences that are happening because of it. And I think as we look at national and regional mortality rates, they're going to be very different. Well, Kathy, I really appreciate you giving us some background on you and your practice and trauma in general, but particularly some of the recent changes. And thank you for making time to chat with me today.
Thank you so much, Dr. Delaney. Have a good day.
Okay, you too.